A 25-year-old young male patient was referred to us for the favor of EUS SOS endotherapy for suspected pseudocyst in the tail of pancreas without obvious evidence of etiology of acute pancreatitis. Now you can see the bile duct. There is resolving edema in the pancreatic head. Patient has severe pain in the left hypochondrium. Other imaging showed pseudocyst in the tail region. You can see the gallbladder here. You can see the bile duct and the pancreatic duct crossing each other perpendicular. In one cross section I could see, which gives me an indication that we are looking at possibly a pancreas divisum in a setting which can possibly be the cause of acute pancreatitis apart from any other biliary etiology. So here you can see the bile duct coming down, the pancreatic head is edematous, and I could not see a classical Steck sign. We are evaluating the part of the gallbladder here at 11 o'clock position now, and we are having a careful evaluation. The balloon is inflated, so we'll deflate the balloon a little bit and try and see. You can see the bile duct again. We are getting into the position to evaluate the gallbladder, and during this maneuver sometimes you may slip out into the stomach, and that's exactly what has happened here. So we are into the stomach. Since we are in the stomach, we'll evaluate the suspected pseudocyst in the tail area. It's a 6 centimeter by 4 centimeter fluid collection in the tail. Obviously there is no evidence of any abnormal vascular structure between the wall of the stomach and the pseudocyst, you can see here, but definite evidence of some debris on the floor of the fluid collection. We are measuring the cystic lesion collection about 6.3 by 3.5 centimeters approximately, but it's causing severe symptoms, and patient also has pain off and on and fever. So there could be some mild sepsis in this collection. So what we have done is, while we are trying to evaluate the gallbladder and the bile duct, we slipped out into the stomach. So we are using that opportunity to be in the stomach and evaluate the cystic collection in the tail, rather than going back again in duodenum. So our evaluation of this pseudocyst is practically over. We know that this is accessible through the transgastric route, and now we are back into the duodenum evaluating the gallbladder. On EUS is a certain evidence that there is a short Steck sign and the pancreatic duct crossing perpendicular to the bile duct, almost certain of possibility of a congenital anomaly in the duct. But what we see in the gallbladder, multiple small stones. So the gallbladder shows multiple small stones. We have seen in our practice that patient with severe acute pancreatitis in young subset usually may have either a ductal anomaly or a gallstone disease. As you can see in this patient, we have probably both possibilities. So you can see multiple stones in the gallbladder. When patient had acute pancreatitis about 6 weeks back, that time ultrasound and other imaging was not showing any stones. Probably they were imaging microliths, or it was missed. So therefore, as we all know, ultrasound and endoscopic ultrasound are operator-independent procedures. We scanned at 12 megahertz. I'm coming back. You can see that cystic lesion again, the pseudocyst in the tail of the pancreas. We could not see the pancreatic tissue in the tail at all. Now we are in the mediastinum. Aorta at 5 and 6 o'clock position, the azygous vein at 9 o'clock. and now at the arch of the aorta, and we are now proceeding with endotherapy. Since we felt that there is probably a communication through the minor papilla, initially major papilla cannulation was performed, which confirmed the presence of pancreas divisum. So we are using a metal tip cannula to cannulate the minor papilla here, and we'll obtain a pancreatogram. And you can see here the pancreatogram is showing free leakage into the tail of pancreas. You can see the big loop position. Let me share with all our enterprising and enthusiastic endoscopists and ERCP exponents who want to venture in minor papilla cannulations that you need to have a big loop position in most cases to get end-on access to the minor papilla, and that's exactly what we have done here. We are trying to get into the minor papilla opening with a hydrophilic wire with a cannula, and once the wire is inside the pancreatic duct, we allow the wire to slide in at a distance in the duct before I push my cannula deeper. Now here a very, very fine collaborative, cooperative work with your assistant is important. It cannot be undermined. Now I'm trying to pass a guide wire, and we fly straight into the cavity with the guide wire. And then we gently push the cannula. You can see my scope is still in the big loop position, very, very unstable position of the tip of the scope, as you can see, but an excellent access, end-on access to the minor papilla is possible only with this kind of positioning in most cases. We are now exchanging the hydrophilic wire for a stiffer wire, and we will remove the cannula over the wire and then load a sphinctertome. So the wire is deep in the pseudocyst, transpapillary, and now we will try and achieve a pancreatic minor papilla sphincterotomy. You can see here it's ideal way to do. We will cut up to the bulging portion. It's extremely difficult to ascertain the completeness of a minor papilla sphincterotomy because sometimes because of edema it's extremely difficult to judge. So try and cut as much as you feel comfortable to allow your interventions rather than going overboard to complete the sphincterotomy. So here I feel it's an adequate sphincterotomy to allow me a passage of instruments. Now I'm doing is a dilatation. There is a short narrowing at the junction of the duct and the leak. You can see the wire well coiled and looped in the pseudocyst, and you can see here that I'm passing a 7 French Sohendra dilator. Now I have straightened my scope in order to maneuver my accessory. So once you have deep in the wire deep into the system, you can possibly straighten the scope out, what you are seeing now, to facilitate smoother passage of biliary dilators. And I'm using Sohendra dilator here, 7 French, to dilate the track in order to place a 7 French double pigtail stents. So we prefer pigtail stents here, double pigtails, so that one pigtail will be in the pseudocyst cavity and the other pigtail in the duodenal lumen. So you can see here my scope is in short loop position, and we are gently pushing the stent across into the cavity. My assistant will gently pull the guide wire out so that the loop of the stent is formed in the cavity, and then the loop of the stent in the duodenum as well. And this establishes proper placement of the stent transpapillary. So this is how we do transpapillary pseudocyst drainage. Transmurally also it could have been done, but this I feel is a safer way in this case.